So you'll see the probes come down. Each of these electrodes will come down. All four come at the same time, but this is just for artist rendition showing one. And it's going into the submucosa where it's delivering energy. So pretty straightforward. But while you're doing this, again, the temperature of the surface and the tip of the needle is being measured, the impedance is being measured, so you're not creating a burn. And as you do it, you gradually turn the device, not with the needles deployed, obviously. And here it shows all four electrodes coming out at the same time. So you go around the patient in four quadrants, though many people avoid anterior women and will do left anterior lateral, right anterior lateral, and deep posterior, more like a chevron shape instead. But at the end, you have all of these different radio frequency spots that have been treated in the patient. Show you what it looks like in real time. So the only prep that the patient has is
the patient's position in the protracted position, having self-administered two disposable phosphate enemas as well.
So you can see how it works here with the number one, I would recommend patients with mild to moderate incontinence, not patients with severe incontinence. This is meant for patients with incontinence of maybe 6 to 12 perhaps in a score. It's not probably efficacious for people with a score of 20. But as we're delivering the energy, you can see here each of the electrodes is going to give a readout in terms of surface and depth temperature and impedance in ohms. So we know that we're not burning the tissue, we know it's not going to get too hot, we have water dripping in. So, I mean, it's a very simple procedure. The patient does not have to have a general anesthetic, but they do need sedation because it's a 3 centimeter diameter probe and you're constantly deploying electrodes. Most people do it in the endoscopy unit. It's a lot more cost effective than going to the operating room. The only prep you need are phosphate enemas. So what I find I do is when I put it in and I deploy the electrodes, I have good surface contact, like if the impedance shoots up, what happens is the electrode will cut out. So you'll see, if it's not good contact, one of these four electrodes will cut out, and I'll reposition it. So in that case, I just retract the electrode back inside and try and get a slightly different angle, usually trying to drive the probes a little deeper. Now, anteriorly in women, you have to be very careful and put fingers in the posterior vaginal wall to ensure that you're not deploying the electrodes through the vagina as you're doing it. You can see at the top, I've mentioned the clock, so the seconds will tick along. Each treatment, for electrode treatment, is 60 seconds, and here all the temperature and impedance stayed fine as we're doing it. You can see the electrodes here, the curved electrodes. You clearly need some form of an anesthetic to do this. And you can see here at the end how water will drip in and suction will come out. This machine keeps track of how many treatments you've been given. You don't even have to do it yourself or your nurse. It'll just give you a tally at the end of exactly how many successful treatments there were. So the cord goes in. It's about 25 minutes because if you do 80 electrodes, that's 20 deployments of the handle. Each one is a minute, 20 minutes, but if you fiddle around a bit, 25 minutes, maximum 30 to do this. See here, this one's cut out, this one's cut out. So it's a safety fallback. If the impedance or the temperature are too high, it cuts out. I always do an anoscopy at the end to show that there's no mucosal burn, which there never is, because the treatment is much deeper than the mucosa. Patient goes home the same day. I usually give single dose perioperative antibiotics. I'm not sure it's necessarily even required, but I feel better doing it. So in the early results from Takahashi from Mexico City, pilot study, you can see 10 female patients followed up for a year, and they had a 50% reduction in 80% of patients in their incontinence score. Better quality of life and better SF-36. Very, very similar data to what we saw for Stretter. Now, the physiologic change seemed to be also similar to Stretter. A higher threshold, so they could somehow hold more, though not by a change in pressure. And you can see that there's no change in resting or squeeze pressure at all. But what there is a change is the ability to, at a lower volume, sense that there's something there, and a better ability to hold a larger amount. So in other words, the compliance somehow seems better. And as I tell patients, it a better early warning system. It lets you know sooner when there's something there so you can get to the toilet. That seems to be the effect. We went on to do a multi-center study, 5 centers, open labeled, and you can see some patients had had a variety of treatments in the past. We followed these patients for 6 months. You can see a significant decrease in the incontinence score. Again, this is not going to be a panacea that patients get scores of 0, but it does give them enough improvement that their quality of life statistically significantly improves in all 4 domains: lifestyle, coping, depression, and embarrassment, social functioning, mental health, all better with that 3 to 4 point improvement in incontinence scores. Some complications, mostly pretty mild complications. Manometry, again, same as was seen in Mexico City, improvement in maximal tolerable volume, improvement in threshold volume. So it's something to do with sensation, not anything to do with scarring. The anal ultrasound did not show scarring. There was no pudendal neuropathy induced and no changes in resting and squeeze pressure, but that'll become more clear in the next talk. Going on to 2-year results from Mexico City, still improved in incontinence scores from 13.8 to 7.3, still improvements in the 4 fecal incontinence quality of life parameters and in the SF36 domains. And you can see there's really little attrition out at 2 years. Quality of life continues to be improved. General quality of life, in addition to the SF36, also improved. Carrying it on further at 5 years, still showing improvement in the Mexico City data from 14.5 down to 8.3. And I would add that throughout the world literature, there are numerous studies that have shown a statistically significant correlation between scores of over 10 and inferior quality of life and under 10 and superior quality of life. So it's good to see that type of number here. As we look through the literature, there's not a lot of studies, and most of the problem has been one relating to reimbursement in the United States. But you can see improvement in the majority of patients in the majority of the studies, and they all seem to relate to improvements in quality of life. Complications tend to be relatively minor in most of these patients. The physiologic changes, again, it's not scarring. Nobody's finding changes in ultrasound. A little tiny fibrosis in the French study, but outside of France, no. And improved sensation, but no change in pressure seems to be the consistent finding throughout the world. Most recently, Marco Frasco from Italy looked at a systematic review, found minor complications in these patients, and the ASCRS task force, we recently came out with a grade 2B recommendation, specifically for patients, as I mentioned, with mild to moderate incontinence, with or without a sphincter defect. We rated it as low overall risk, intermediate efficacy. This consensus document has been published this past year in surgical endoscopy. There are obviously certain contraindications. If the patient has stenosis, clearly you're not going to jam in a 3-centimeter diameter probe and then deploy electrodes. And there are certain potential complications: pain, bleeding, infection, mucosal ulceration, although all of these things are very, very mild indeed. So, in summary, it's a pretty non-invasive procedure, relatively non-invasive when we think about artificial valve sphincter, sacral neuromodulation, and other similar procedures. It can be done as an outpatient in the endoscopy unit with some sedation, with the expectation of reasonable improvement, not perfection, low complication rate, and it may be a good bridging option. The patient who isn't sure that they want a magnetic sphincter, artificial valve sphincter, ursoloplasty, but they're tired of being incontinent, they don't want a stone, they failed the sphincter repair, they're not candidates for sphincter repair. This is a huge group of patients in whom I think radiofrequency offers a tremendous opportunity to have an improvement in quality of life, and momentarily we'll hear why that